Dear chairs, dear audience, my name is Patrik Kreuter, and I'd like to introduce my PhD topic, the latest advancements in digital orthodontics. I'm a second-year resident at the Department of Pediatric Dentistry and Orthodontics. My supervisors are Noémi Rózsa and Dorottya Bányai. My SMS is Eszter Szalai. My vision is to help more people smile confidently, and my mission is to contribute to the development of orthodontic guidelines, providing high-quality treatments without compromise. I have two ongoing projects. Both of them are systematic reviews and meta-analysis. The first one is titled Investigating the Differences in Root Resorption between Fixed Appliances and Aligners in Permanent Dentition. Fixed orthodontic appliances often cause aesthetic and hygienic difficulties during the treatment. However, aligners are more comfortable and aesthetic, and they are associated with less periodontal risk and improved patient satisfaction. Orthodontic treatment often causes orthodontically induced inflammatory root resorption, which is an irreversible side effect of orthodontic treatment. Aligners previously showed lower prevalence and severity of root resorption on radiographs. However, more accurate CBCT studies have been conducted only recently. Our aim is to investigate the effect of aligners versus fixed appliances on root resorption. Our clinical question is how the aligners perform in terms of root resorption compared to fixed appliances. We use the PICO framework, where the population is patients with permanent dentition. The intervention is aligners compared to fixed appliances, either conventional or self-ligating ones. The primary outcome is root resorption as a linear measurement on CBCT recordings. The secondary outcome is the same measurement on radiographs. The hypothesis is that aligner therapy causes less severe root resorption compared to fixed appliances. We've conducted the systematic search with the following search key, and I would like to shortly introduce our results of the 6 articles we found eligible. The first forest plot shows the root resorption of upper central incisors treated with aligners versus fixed appliances. The outcome here is a millimeter measurement, the mean of the differences. We can state that the decrease of root length is clinically insignificant if it's below 1 millimeter based on previous studies. The first forest plot represents 5 retrospective cohort studies with almost 300 patients. We have variable I-square values from 48% to 99%. It presents high heterogeneity between and within the groups. None of the groups presented a clinically significant root resorption. The aligner group with 0.68 millimeter and the fixed appliance group with 0.89 millimeter is clinically insignificant as well. Also, we didn't have a clinically nor statistically significant difference between the groups, so we can state that the upper central incisors do not differ clinically significantly in this matter. The second forest plot is a subgroup analysis of the fixed appliances. Here we have the same outcome. None of the groups presented a clinically significant root resorption, and there wasn't a statistically significant difference between the groups. The third forest plot is analyzing the root resorption of upper lateral incisors. From previous studies, we know that these are the tooth types that are most prone to root resorption, but neither here can we see a clinically significant difference between the initial and the end treatment root length. None of these values reached clinical significance, and there wasn't a statistically significant difference between these two groups. Unfortunately, we did not have enough articles to make a complete subgroup analysis of fixed appliances in this case, but we've plotted our results. The strengths of our study is that it's the first quantitative analysis based purely on CBCT studies, and only 2 arm studies were included. The subgroup analysis was also available of conventional and self-ligating fixed appliances. The limitations are that only retrospective cohort studies were included, and there was a high heterogeneity. Most of the studies also presented at least a moderate risk of bias. Our conclusion is that aligners and fixed appliances cause similar amount of root resorption. The clinical implication is that both these interventions can be used safely for patients who do not present the known risk factors. Also, self-ligating appliances are not superior compared to fixed appliances, and as most of the results were not clinically significant, we do not advise the use of CBCT measurements as a routine tool for controlling root resorption. The implication for research is that there's a lack of high-quality RCTs in this topic, and also further studies should investigate the risk populations, and more standardized populations, interventions, and outcome measurements would be necessary in the future. We had 3 submissions yet, the latest one in the Progress in Orthodontics. As we have been rejected recently from here, our next target journal is the American Journal of Orthopedics and Dentofacial Orthodontics. The second project is titled Analyzing Transfer Accuracy and Debonding with 3D Printed Indirect Bonding Trays. The conventional direct bonding of fixed appliances requires high precision, as the misplacement of the brackets can cause unwanted tooth movement. Indirect bonding offers more predictable and precise bracket placement. It decreases the chair time and also the treatment time. The most novel approach to indirect bonding is the implementation of 3D printing. These 3D printed indirect bonding trays look like just the one on the picture. As you can see, the brackets are placed individually in the tray and then placed all together on the dental arch. Previous studies are contradictory, and there isn't enough evidence available suggesting that it's clinically acceptable in terms of accuracy, and also some research suggests that it may be inferior in survivor. Our aim is to assess the transfer accuracy and debonding rate achieved with 3D printed indirect bonding trays. Our clinical question is how do 3D printed indirect bonding trays perform in terms of transfer accuracy and debonding. Here we use the PICO framework as well. The population is orthodontic brackets, and the interventions are different types of 3D printed indirect bonding trays. Our primary outcome is the transfer accuracy, both as linear and angular measurements. The secondary outcome is bracket debonding. Our hypothesis is that 3D printed indirect bonding trays are clinically acceptable in terms of accuracy and debonding, and the clinical implication would be reproducible bracket positioning with low failure rate. Here we can see our preliminary research, and right now we are working on the Prospero registration. To summarize, I have 2 ongoing systematic reviews and meta-analysis in the topic of digital orthodontics. And I would like to thank you for your attention with a quote from Carl Sagan: "Somewhere something incredible is waiting to be known." Thank you for your kind attention.
My first question, before I ask the audience, that what was the reason of the rejection? The primary reason.
So the first 2 journals, did not give any reasoning. The third one gave a short list of the reasonings. One of them was that the search is outdated, so now we're going to do the search again. One of them was that we didn't check the risk of bias, which we did indeed. And also it said that we didn't do citation chasing, which we did and discussed.
So it basically was an editor
yes,
level,
yes.
Not a reviewer?
No,
not a detailed reviewer. Okay.
Yes.
And my second question, how did you get this 1 millimeter for clinical relevance?
Yes. So it was a tough question because previous meta-analysis used 1 millimeter, but actually the Sharpe classification, for example, says that below the 1/3 of the root, we can say that it's only a mild root resorption. So actually this 1 millimeter is quite arbitrary based on the literature, and it's too strict, but even with this strict cutoff level, we didn't find any clinical significance. So with normal cutoff values, which do represent the clinical significance, we would find that these articles that are included are even less relevant.
But as far as I understood, that maybe all or most of the result was significant statistically.
No, there wasn't a statistical significance between the groups.
There was?
No.
There was not? There weren't? Okay, so then I misunderstood.
Yes, yes. Okay. So none of the groups were clinically relevant in terms of root resorption, and they did not differ from each other significantly.
Okay, then it makes sense. Okay, I'm just, because I was wondering that even one resorption is dramatic, so
yes.
I wouldn't set up a clinically relevant value. I would more rely on the statistics than in this special case.
Yes.
In your first project, I was wondering, did you guys think about doing a subgroup comparative, so angle class 1, angle class 2, because it's very different. Did you think about actually subgrouping instead of like just pulling it together?
Yes, thank you for the question. So the reason why I have a separate column in the forest plots is just to showcase the different angle classifications.
Okay.
So it's one of the biggest confounding factors, and I think a big reason for the heterogeneity,
right.
but we did not have enough articles to subgroup it.
Okay.
Yes.
Thank you. And the other question would be, I saw that you were looking into aligners and fixed appliances, and then you compared fixed appliances between the two groups, but did you think about seeing aligners versus like just the conventional, or aligner versus the self-ligaturing, because it also has a bit of a difference between those two? Or did you just pull together fixed appliances because you think it wouldn't
yes,
matter in that sense?
Yes, so to have a higher statistical power, we did pull them together
right.
to compare them. And we did not have enough articles to just pull together the aligners and the separate fixed appliances.
Okay.
But as within the subgroup analysis and within the big analysis we did not have any difference, then we can state that there's no difference. However, we have to state that it's made on groups that are not prone to root resorption, so they did not present the known risk factors. Mm-hmm. The inclusion of the patients in these studies usually stated that they did not have dental trauma, developmental issues, or previous root resorption. So these results may vary in a population that do have the risk factors for root resorption.
I just looking at your slides, because maybe my eyes is wrong, but because everything is minus in the confidence interval. That's why I thought that everything is significant.
Yes, so the reason why everything is minus is that it was a millimeter measurement and it was a decrease.
Yeah.
So every
But that
result
means that doesn't reach the zero value, so that's statistically significant, if I'm right.
So the comparison of the groups was not statistically significant, as the confidence intervals overlap of the two groups. So all groups.
So you don't have these are not mean, not difference value. These are
no.
Mean.
Yes, these are means.
Okay.
Yes, yes.
And you don't have an analysis for the mean value because they are not two-arm studies, or why?
So they are two-arm studies, and these are the means of the root resorption itself. And all of the groups presented root resorption, so all of them are minus. But none of them reached 1 millimeter, so they're not clinically significant. And the difference between the groups, so how much root resorption they had as the confidence intervals overlap, they're not statistically different.
You don't show that the mean difference?
Yes.
You don't have a slide, or you don't have an analysis for the mean difference itself?
No separate analysis for that, yes.
How common of a problem is root resorption in the population?
Thank you for the question. So as I've shown on a previous slide, most of the patients who are treated with orthodontic appliances do show signs of root resorption. So within the orthodontic population, depending on which population we investigate, almost all patients have root resorption. However, usually we can only see it on the radiographs, and it's only a slight blunting of the apex of the teeth. So clinically, it's not relevant in most of the cases.
So what percent is it noticeable?
Noticeable, about 1 to 2% in the orthodontic population.
If we could go back to the previous forest plots, please.
Sure.
This is not a question, but a comment. I know this is statistics, but the prediction interval looks a little strange that it shows plus numbers. Yeah, and my question would be, how old were these patients in the study?
Thank you for the questions. The prediction interval is not accurate because we didn't have too many studies, but actually none of them presented positive root length change, unfortunately. So all the values were negative. And they didn't have an age restriction. The restriction was that it's permanent dentition and a complete permanent dentition, so no missing teeth was available. But the population differed from about 17 years old up to the mid-30s.
Thank you. And one extra question, if you allow that. How prone are the root canal treated teeth to this orthodontic resorption?
Thank you. That's a very good question. Actually, some of the articles show that root canal treated teeth are less prone to root resorption, which I found interesting, but all of the articles excluded teeth that are root canal treated.